Good evening, everybody. I am Dr. Liaquat Ali Gori, Senior Professor and Head of Rheumatology at SP Medical College, Bikaner. Principal and Controller, former with addition charge, SP Medical College, Bikaner. Today, I am going to present recent trends in management of rheumatoid arthritis. Rheumatoid arthritis is a chronic inflammatory disease of unknown etiology characterized by symmetric point arthritis, the most common form of chronic inflammatory arthritis. It affects 0.5 to 1% population worldwide. Incidence of RA increases between 25 and 55 years of age, after which it plateaus until the age of 75 and then decreases. Patient complains of early morning stiffness lasting for more than 1 hour that improves with physical activity. Earliest involved joints are typically small joints of hands and feet. Joint involvement is symmetric. Progressive destruction of joints and soft tissues may lead to irreversible deformities, which includes ulnar deviation, swan-neck deformity, bottomley deformity, jadal line deformity. Can lead to pes planovalgus, flat feet. Atlantoaxial involvement of cervical spine may evolve over time with progressive instability of C1 on C2. Extra-articular manifestations may develop during clinical course of RA in up to 40% of patients even prior to onset of arthritis. Extra-articular manifestations include pulmonary. Pleural effusion tends to be exudative. ILD presents as dry cough and progressive shortness of breath. Prevalence of ILD in RA is as high as 12%. Pulmonary function tests show a restrictive pattern with decreased diffusing capacity for carbon monoxide (DELCO), associated with a 10% increase in mortality. Cardiac. Pericardium is most frequently involved, occurs in less than 10% of patients. Mitral regurgitation is the most common valvular deformity in RA. Vasculitis occurs in long-standing disease, incidence is less than 1%. Hematologic. A normochromic micronormocytic anemia is the most common hematology abnormality. The degree of anemia parallels the degree of inflammation. Flaherty syndrome, clinical triad of neutropenia, splenomegaly, and nodule RA, seen in less than 1% of patients. Osteoporosis, more common in patients with RA than age and sex mixed population with prevalence rate of 20 to 30%. Hypoandrogenism. Men and postmenopausal women with RA have a lower mean serum content testosterone, luteinizing hormone, and DHEA level than control population. Genetic and environmental consideration. Genetic factors contribute to the occurrence of RA as well as to its severity. First-degree relatives of RA patients will share the diagnosis 2 to 10 times greater than the general population. Alleles known to confer the greatest risk are located within the major histocompatibility complex. 13% of genetic risk for RA resides within this locus. Cigarette smoking increases the risk by 2.5 times. Epstein-Barr virus infection. Porphyromonas gingival is oral microbe found to be involved in RA. Diagnosis. RA is diagnosed according to ASIA-EULAR criteria 2010, which takes into consideration joint involvement, serology, positive or negative rheumatoid factor, and anti-CCP antibodies, level of acute phase reactants, and disease duration. A score of more than 6 per 10 is diagnostic. Joint imaging. On radiograph, symmetric joint space loss and subchondral erosions, joint subluxation, and collapse can be seen. MRI, greatest sensitivity for detecting synovitis and joint effusions as well as early bone changes. Clinical course. The overall mortality in RA is 2 times greater than general population, with ischemic heart disease being the most common cause of death, followed by infection. Median life expectancy is shortened by an average of 7 years for men and 3 years for women compared to control population. How to treat? Several developments during past 2 decades have changed the therapeutic landscape in RA. emergence of methotrexate as disease-modifying anti-rheumatic drug, development of novel, highly efficacious biologicals that can use with or without methotrexate. Treatment options can be divided into NSAIDs, glucocorticoids, conventional DMARDs, biological DMARDs. NSAIDs. They are now used as adjuvants only. Chronic use should be minimized due to side effects like peptic ulcer disease and impaired renal functions. Glucocorticoids. Administered in low to moderate doses to achieve rapid disease control before the onset of fully effective DMARD therapy, which may take several weeks or months. A 1 to 2 week burst of glucocorticoids may be prescribed for management of acute disease flares. Chronic administration of low dose, that is 5 to 10 mg per day of prednisone in patients with an adequate response to DMARD therapy. Intra-articular injection of an intermediate-acting glucocorticoid such as triamcinolone acetonide can be given. Disease-modifying anti-rheumatic drugs. They slow or prevent structural progression of RA. Include hydroxychloroquine, sulfasalazine, methotrexate, leflunomide. Takes 6 to 12 weeks in onset of action. Methotrexate is the DMARD of choice, remains the benchmark for efficacy and safety, can be used as monotherapy or in combination with other DMARDs. Biologicals revolutionized the treatment of RA over the past decade. These are protein therapeutics designed to target cytokines and cell surface molecules. The most noticeable are TNF-alpha inhibitors. They were the first biologicals approved for treatment of RA. These are etanercept, infliximab, adalimumab, cetuximab, golimumab. These agents should be avoided in patients with active infection or chronic hepatitis B or class 3-4 congestive failure. They can cause reactivation of latent tuberculosis. Rituximab, monoclonal antibody CD20 on B lymphocytes, has been approved for treatment of refractory RA in combination with methotrexate. A few cases of progressive multifocal leukoencephalopathy have been reported. Treatment of extra-articular manifestations. Treatment of underlying RA favorably modifies extra-articular manifestations, and aggressive management of early disease can potentially prevent their occurrence in first place. RA-ILD can be particularly challenging to treat because some of the DMARDs used for treatment of RA are associated with pulmonary toxicity such as methotrexate and leflunomide. High doses of corticosteroids and adjuvantive immunosuppressants agents such as azathioprine, mycophenolate mofetil, and rituximab has been used for treatment of RA-ILD. RA and pregnancy. 75% of female RA patients will note oral improvement in symptoms during pregnancy, but often will flare after delivery. Flares during pregnancy are treated often with low-dose prednisone, hydroxychloroquine, sulfasalazine. Methotrexate and leflunomide are contraindicated. Summary: RA is a systemic disease affecting joints but can lead to various extra-articular manifestations. RA as a disease is often underestimated by the general population as well as clinicians, but has proved to increase mortality and morbidity. And awareness about the disease and it is important. Its treatment needs to be raised to improve the quality of life. Thank you for your kind attention.